Welcome everyone. My name is John Fitzgerald, and today I'll present an update on the subject of interstitial lung disease. The umbrella of interstitial lung disease encompasses a large number of potential etiologies, both known and unknown. It can be caused by many different medications, by collagen vascular diseases, by exposures to things like asbestos or silica dusts, and by a variety of genetic mutations. Among the idiopathic interstitial pneumonias, IPF, or the idiopathic form of usual interstitial pneumonia, is by far the most common, making up about a third of all the cases of interstitial lung disease we see. Then we have our granulomatous ILDs, led by things like sarcoidosis and hypersensitivity pneumonitis, and a bunch of unique entities that don't really belong in any particular box, like pulmonary alveolar proteinosis, Langerhans cell histiocytosis, or eosinophilic pneumonia. But as primary care physicians, you should really just focus on recognizing the four entities which account for the large majority of cases you will encounter: IPF, connective tissue disease, sarcoidosis, and hypersensitivity pneumonitis. And that's what we're going to discuss today. Our first case presentation is a 68-year-old man with progressive shortness of breath for 2 years and a dry cough for about a year. He initially presented with atrial fibrillation and RVR. He had increased interstitial markings on the chest X-ray, but that was attributed to pulmonary edema. He was rate-controlled and anticoagulated, and his dyspnea initially improved, but then it gradually worsens. His only medications were the metoprolol and warfarin. He had no other significant past medical history. He was a reformed smoker with a 25-pack year exposure history. There were no family history of lung problems or autoimmune disease, no exposures to fibrogenic dusts, mold, or feathers, and he had a completely negative connective tissue disease review of systems. On exam, he had the atrial fibrillation, late inspiratory dry crackles that predominated in the lung bases. Digital clubbing was evident, as you see here, and he had no rashes, preserved strength, no synovitis. His pulmonary functions revealed a moderate degree of restriction with a severe decrease in diffusing capacity. His chest radiograph evolved to show further reduction in lung volume size with these coarse reticular markings. A high-res CT indicated subpleural fibrosis with honeycombing and traction bronchiectasis, and an apical basal gradient confirming a pattern of usual interstitial pneumonia. When you have a case of pulmonary fibrosis, you first ask the question, are there identifiable causes for the interstitial lung disease? If the patient has a 10-year history of rheumatoid arthritis, then he has rheumatoid lung disease, not IPF. If he has a pair of African gray parrots in the living room, he probably has avian hypersensitivity pneumonitis. Maybe your patient is an older woman with recurrent urinary tract infections, and her urologist started her on chronic nitrofurantoin therapy, a known cause of ILD. But if a careful history doesn't suggest an identifiable cause, we rely on the pattern of ILD seen on the high-resolution CT scan. That scan may show definite UIP, or it may indicate a pattern of probable UIP, be indeterminate for UIP, or suggest an alternative diagnosis altogether. Well, we take that information to the multidisciplinary discussion with a group of ILD-focused pulmonologists, pathologists, and thoracic radiologists. They may determine they already have enough information to diagnose the patient with IPF, or they may want a bronchoscopy or surgical lung biopsy to provide more information before determining the best diagnosis for that patient. the multidisciplinary discussion is considered the standard of care for the diagnosis of interstitial lung disease. Now, our patient had a negative autoimmune panel of labs, and given the UIP pattern on HRCT, no surgical lung biopsy was required. Finding definite UIP on a high-res CT indicates a greater than 90% probability of finding UIP on a lung biopsy, so we don't need to proceed down that path. The patient was diagnosed at MDD with IPF. He was initiated on antifibrotic therapy, which slows the rate of progression of disease. It doesn't stop it, and it doesn't reverse it. It only slows the rate of progression. He was also referred for an initial lung transplant consultation, not because he needed it initially, but this is a relentlessly progressive process, and it's best to get all your ducks in a row before the situation presents with greater urgency. Now, there are two approved therapies for IPF, pirfenidone and nintedanib. The mechanism of action by which pirfenidone reduces collagen accumulation is not entirely clear. It appears to have inhibitory effects on a number of profibrotic cytokines like platelet-derived growth factor and transforming growth factor beta. It also appears to downregulate certain pro-inflammatory cytokines like TNF-alpha and IL-6, and it's an adept scavenger of certain reactive oxygen species such as hydroxyl radicals. At the same time, it appears to upregulate matrix metalloproteinases and collagenases. What it does clinically is slow the rate of progression of disease by reducing the rate at which forced vital capacity is lost over time. In the ASCEND and CAPACITY trials, patients treated with pirfenidone lost 41% less vital capacity at 1 year compared to patients on placebo. Looking at the pooled data, all-cause mortality was also reduced at 1 year with a hazard ratio of 52% with regard to risk of death. The Empire Patient Registry provided evidence of a longer-term survival benefit, with 56% of pirfenidone-treated patients being alive at 5 years versus only 32% of patients who did not receive antifibrotic therapy. The other approved antifibrotic agent, nintedanib, is a tyrosine kinase inhibitor with multiple targets. It has broad inhibitory activity on the downstream signaling cascades of fibroblasts via the fibroblast growth factor receptor and platelet-derived growth factor receptor, and potentially also on cells involved in angiogenesis within the lung by affecting signaling through the VEGF receptor. In the IMPULSIS and TOMORROW trials, nintedanib also reduced the rate of loss of lung function in IPF patients by about half compared to placebo. Nintedanib initially has shown an effect on reducing the risk of acute exacerbations of pulmonary fibrosis. Acute exacerbations happen to about 5% of patients with pulmonary fibrosis per year. They represent usually the superimposition of diffuse alveolar damage on top of the chronic fibrosis, and they are associated with a mortality rate as high as 80% at 3 months. So reducing the risk of exacerbations is a pretty big deal. Well, according to the pooled data from the big trials, the hazard ratio for developing an acute exacerbation for patients on treatment was just 53% versus placebo. Our second case is a 38-year-old woman with a 3-month history of fatigue, shortness of breath, myalgias, and subjective fevers. Her plain film showed bilateral ground glass opacities. She had no interesting exposures and a negative family history of lung or autoimmune disease. Her PCP was worried about a possible collagen vascular disease, so he sent an ANA and rheumatoid factor level, which were negative. Her PFTs showed moderate restriction and diffusion impairment. She had scant inspiratory crackles on exam, with a bit of muscle tenderness, but no overt weakness. Her hands showed roughness and cracking of the fingertips and lateral aspects of the digits consistent with mechanics hands. And a CT revealed subpleural and peribronchial vascular ground glass opacity with small patches of consolidation suggesting cellular nonspecific interstitial pneumonia with patches of organizing pneumonia. The patient's CK and aldolase were markedly elevated despite the negative ANA and rheumatoid factor. ENA testing revealed a strong positive anti-Jo1 antibody, and an MRI of the shoulder confirmed the presence of muscle inflammation. The patient was confirmed to have polymyositis-related interstitial lung disease with antisynthetase syndrome featuring the Jo1 antisynthetase antibody and the mechanics hand rash. The patient was initially treated with 80 milligrams a day of prednisone. Then mycophenolate was added as a steroid-sparing agent with improvement in her pulmonary function. But she had continued issues with her muscle enzymes and skin, which necessitated the addition of IVIG. After all that, we saw the skin clear up, the muscle enzymes come down, and the PFTs and chest imaging improved substantially, as you see here. Whenever you encounter a patient with interstitial lung disease, you must go through a methodical and complete connective tissue disease review of systems in each and every case. If you just ask about inflammatory arthritis and skin rashes, you may miss important clues to the etiology of your patient's condition. In some cases, the only clue to an underlying connective tissue disease might be their Zika symptoms or the presence of Raynaud's phenomena. So ask all the questions all the time. The same goes for the serological evaluation. In the last case, the PCP ordered an ANA and rheumatoid factor level because he suspected collagen vascular disease, but those tests were negative. Everyone with ILD needs to have an ANA, ENA, rheumatoid factor, CCP, CK, and aldolase. And if your patient has any symptoms to suggest an inflammatory myopathy, or if their CK or aldolase is abnormal, then they need to have the extended myositis antibody profile that you see on the right side of your screen, which includes the other anti-tRNA synthetases, the myositis-specific antibodies like MI2 and MDA5, and the myositis-associated antibodies, which can be seen in myositis or sometimes in other connective tissue diseases like Sjogren's or scleroderma overlap syndromes. Now remember that connective tissue disease accounts for about 15% of all ILD and can be associated with several different forms of interstitial lung disease. And those conditions may have different treatments and have radically different prognoses. The good thing is that we can usually separate these ILDs based on the high-res CT appearance and the clinical presentation. We almost never need to do a lung biopsy on these patients to figure out our next move. We just need to know if it's an acute, subacute, or chronic process. If it has mainly ground glass, like this patient with cellular NSIP in the setting of polymyositis, or consolidation, like this patient with lupus and organizing pneumonia, or fibrosis, like this patient with rheumatoid arthritis and UIP. And we get a head start by simply knowing which connective tissue disorder we're dealing with. You see, there are 5 different patterns of ILD that we can see in patients with collagen vascular disease: diffuse alveolar damage, lymphocytic interstitial pneumonia, organizing pneumonia, usual interstitial pneumonia, or nonspecific interstitial pneumonia. But the percentage of the different ILDs varies a lot depending on which underlying connective tissue disorder we're dealing with. So, for example, with systemic sclerosis, 70% of the ILD we encounter is fibrosing nonspecific interstitial pneumonia. In polymyositis, it's 50% cellular or mixed NSIP and 20% organizing pneumonia. In Sjogren's syndrome, it's about 40% fibrosing NSIP and 40% lymphocytic interstitial pneumonia. We can almost always figure out what we need to do without resorting to risky lung biopsies in these patients if we just have this basic clinical and radiologic information. Now, current treatments of CTD-ILD are primarily directed at the inflammatory response, specifically at the lymphocyte. And these include corticosteroids, mycophenolate, azathioprine, cyclophosphamide, tacrolimus, and rituximab. Controlled trials demonstrating the efficacy of corticosteroids in CTD-ILD don't actually exist. But there are certain types of ILD that clearly do respond well to corticosteroids. And these are usually easy to recognize because they are characterized predominantly by ground glass or consolidation without radiographic evidence of fibrosis. Here we have a patient with rheumatoid arthritis and organizing pneumonia featuring peripheral consolidation as well as ground glass opacity. After treatment with steroids, this patient had resolution of the consolidation with persistence of just some mild ground glass. Other types of interstitial lung disease that respond favorably to steroids in the setting of connective tissue disorders include diffuse alveolar hemorrhage, the cellular form of NSIP, most cases of LIP, and some cases of diffuse alveolar damage. Cytotoxics are used a lot in CTD-ILD patients for systemic disease control, as steroid-sparing agents, or for steroid-resistant forms of interstitial lung disease. We always start with a combination of mycophenolate or azathioprine plus low-dose steroids when we're dealing with the common presentation of fibrosing or mixed cellular and fibrosing NSIP. We usually prefer mycophenolate, at least if inflammatory arthritis isn't a big problem for the patient, because in addition to targeting lymphocytes, mycophenolate has antifibrotic properties related to its effect on the proliferation of non-immune cells, including fibroblasts and smooth muscle cells. Now, for severe, rapidly progressing forms of ILD, we sometimes employ cyclophosphamide, especially in patients with scleroderma, tacrolimus, especially in patients with the inflammatory myopathies or antisynthetase syndrome, or rituximab in any of the collagen vascular diseases with rapid progression. On the basis of the Census trial, the FDA has also approved the use of nintedanib in scleroderma-associated ILD since 2019. In this trial, as in IPF, we see that nintedanib considerably slows the rate of loss of vital capacity in these patients, about half of whom were also receiving mycophenolate at baseline. Indeed, many patients treated with both actually had arrest of their disease progression over the treatment period. So initially, nintedanib was approved for use in scleroderma, but the INBUILD study that followed confirmed that the drug is actually useful in progressive pulmonary fibrosis from any etiology, including the other connective tissue diseases, idiopathic NSIP, sarcoidosis, and hypersensitivity pneumonitis. And it didn't matter whether the patients had a UIP pattern or not. The next case is a 62-year-old woman with a several-year history of cough and dyspnea. Her exam showed scattered crackles with extensive inspiratory squeaks. Her PFTs showed moderate to severe restriction and a moderately reduced diffusing capacity. The CT showed mid to upper zone predominant ground glass opacity and reticulations. And the expiratory cuts showed patchy air trapping, like you see here and here. Now, when you have a patient with ILD and squeaks on exam and air trapping on the CT, that dramatically alters the differential diagnosis for the patient's ILD. That combination almost always means one of two things: connective tissue disease or hypersensitivity pneumonitis, because those two conditions often simultaneously cause both interstitial scarring and bronchiolitis. The patient's connective tissue disease review of systems was completely negative, but she reported a lifelong history of sleeping on down pillows with feather comforters. A bronchoscopy was performed demonstrating a very high percentage of lymphocytes on BAL, and the patient was diagnosed at MDD with chronic avian hypersensitivity pneumonitis. Now, the only other disorders capable of causing BAL lymphocytosis to this degree are sarcoid and LIP, and neither of those conditions fit clinically with this patient's presentation. In the majority of cases of hypersensitivity pneumonitis, when we remove the patient from the offending antigen source, their condition often stops progressing and sometimes improves. But that didn't happen here. In spite of antigen removal and a 2-month steroid taper, the patient's disease progressed. At that point, mycophenolate was added, but she still progressed. She ultimately required lung transplantation, and the explant pathology confirmed changes consistent with chronic hypersensitivity pneumonitis. Hypersensitivity pneumonitis accounts for about 15% of all ILD cases. It is the most missed interstitial lung disease diagnosis prior to heading to the multidisciplinary discussion. It's a granulomatous disorder affecting the interstitial space, small airways, and alveoli related to repeated exposure with sensitization to various organic or chemical antigens. Hypersensitivity pneumonitis is usually due to mold or feather antigen exposure in a large percentage of cases. So you always want to ask about things like water damage to the home, the use of humidifiers, hot tubs or saunas, or damp crawl spaces underneath pier and beam houses. Patients with avian HP usually have a history of being bird fanciers or raising chickens, but they sometimes simply sleep on feather pillows. There's a subacute form we commonly see in farmers after baling a bunch of moldy hay, and these cases may present with fever, chills, arthralgias, fatigue, and widespread centrolobular ground glass opacities like you see in that top slide. But mostly, we encounter chronic hypersensitivity pneumonitis, which presents mainly or exclusively with respiratory symptoms and more fibrotic changes and air trapping on the CT scan. The most important factor in the treatment of hypersensitivity pneumonitis is removal from antigen exposure. Progression in spite of pharmacologic treatment is common if the patient remains in the exposure. Prednisone is first-line therapy, with mycophenolate or azathioprine being used for progressive or refractory disease or for steroid intolerance. And the data is probably best here for mycophenolate. Antifibrotic treatment with nintedanib can also be used for patients who have progressive disease. Your survival, if you have HP, is very much dependent on whether or not you're able to identify and remove the offending antigen. No matter how many questions we ask, about 25% of the time we can't figure out where the disease is coming from. And it can be from the workplace or in the home. The top two lines on this slide show the survival probability over 25 years for patients with HB without fibrosis on their initial scans, depending on whether they had an identified inhalation antigen or not. These patients had an antigen detected. These ones did not, and their survival was not as good. The bottom two lines show the same thing for the HP patients who had fibrosis when they initially presented. Fibrosis is never good prognostically, but at 10 years, you can see that over 40% of the patients with an identifiable antigen were still alive, versus only about 25% of the patients without an identified antigen. The fourth presentation is a 61-year-old Hispanic woman with a complaint of headache for 8 months. She had lytic lesions on her head CT. She was informed she likely had cancer and was referred to oncology. A pan-CT was completed, revealing perilymphatic nodular infiltrates in the lung. The patient actually had no respiratory symptoms. She had a normal physical exam, a near normal set of pulmonary function tests, and an ACE level of 71, so at least somebody was thinking about the possibility of sarcoidosis. She was sent for a surgical lung biopsy due to concern for malignancy, but that revealed numerous non-caseating granulomas with multinucleated giant cells, no polarizable material, and negative fungal and acid fast smears. So the conclusion was she had sarcoidosis as a diagnosis of exclusion. Sarcoid accounts for 10 to 30% of all the ILD we encounter. It's a multisystem granulomatous disorder of unknown etiology featuring bilateral hilar lymphadenopathy, mediastinal lymphadenopathy, and pulmonary reticular or nodular opacities. It can affect virtually any organ or tissue in the body, but it especially commonly involves the skin, joint, and or the eye, in addition to the thoracic involvement. Sarcoid treatment usually involves corticosteroids as first-line therapy. We utilize prednisone at a dose of 0.3 to 0.6 milligram per kilogram per day, usually 20 to 40 milligrams a day, depending on the disease activity. We do use much higher doses for patients with life-threatening cardiac, neurologic, or respiratory failure. We like to reassess patients at 6 weeks and then begin a slow taper to 10 to 15 milligrams a day at that point. Usually, though, we're continuing the treatment for at least 1 year. Alternative agents that can be used for patients who have refractory disease or for steroid intolerant patients, or simply to minimize the steroid dose in patients that are experiencing side effects. We use things like methotrexate, azathioprine, leflunomide, mycophenolate, infliximab or adalimumab, hydroxychloroquine, and in cases of progressive fibrotic disease, nintedanib. There are cases where you can safely observe the patient without therapy. We very commonly see patients in clinic who are suffering from the effects of massive overdosing with steroids when they never actually even had a clinical indication to begin treatment. Asymptomatic patients with stage 1 chest x-rays, that's just hilar or mediastinal lymphadenopathy, well, 60 to 80% of those patients will achieve spontaneous remission. For asymptomatic stage 2 patients, that's hilar adenopathy and interstitial infiltrates, we recommend watching those patients for 3 to 6 months before instituting therapy to see what direction their condition is going. 50% of these patients will also resolve spontaneously by 36 months. We can also watch asymptomatic stage 3 patients with normal PFTs or mild changes. So in summary, most interstitial disease is made up of IPF, CTD-ILD, hypersensitivity pneumonitis, and sarcoid. Honeycombing does not equal IPF. All four of those entities above are capable of producing honeycomb lung. You always want to ask about exposures to fibrogenic dusts like silica or asbestos, to fibrogenic medications like amiodarone, methotrexate, or chemotherapeutics. And we want to know about mold or feather exposures. You want to perform a complete connective tissue disease review of systems and serologies on every patient with undiagnosed ILD. Refer the patient to an ILD center for a multidisciplinary discussion if the diagnosis is uncertain. And remember, don't just start an antifibrotic because you may miss an important exposure or better treatment alternative for your patient. Thanks for your attention.